four topics which are extremely important. Critical management of coronary artery disease. The first talk is on pharmaco-invasive therapy by Dr. Sirish Hiramat. Just like in the morning session, we would ask Dr. Hiramat to present his presentation. In between, we would and ask him questions whenever there are some practical questions to be discussed, so that it becomes a much more interactive session. Hiramat, please.
Yeah, so we are in a post-lunch session. I must warn you, there are 4 cameras which is on, so it can catch you. One of the staff who works with me, every afternoon she sleeps, and every time we ask her, so you can say you are meditating and get away. So let us, when we talk of MI, we talk or angioplasty, or today we are trying to say that we are going to combine the two, what is called as a pharmaco-invasive therapy. So thrombolysis, that is the simple meaning of this. Dr. Madikar, you're here. So I'm showing you a case. This is a case who presented with chest pain while playing tennis. Now this is a 45-year-old, no risk factors, typical pain while playing, and before he arrived at. Now, as you know, routine place angioplasty goes on. So we had no reasons to not accept the patient for primary angioplasty after the onset of chest pain. But that particular day was a Sunday, it was Anant Chaturdashi, the last day of Ganpati, and Pune traffic is completely blocked on this particular day. So we sort of calculated and we realized to take at least 3 hours to get going and to take the patient to the cath lab. You can see there are acute or hyperacute kind of T-wave changes in the anterior lead, somebody who is just getting into an infarction. And at this stage, as I told you, this is 8 o'clock in the evening, lag time was more than 120 minutes, it was about 3 hours before I could have taken the patient to the cath lab. So any comments as to how we proceed from here? Anybody? Madikar, you start or?
No, as per the guidelines, if you are unable to provide PCI.
It's very clear.
Yeah, within 3 hours,
3 hours,
there is an option of thrombolytic therapy.
Anybody has any other view?
No, not only 3 hours, but if the time between thrombolysis and angioplasty, expected time to thrombolysis versus expected time to angioplasty is more than 60 minutes of thrombolizing the patient, reaches hospital. So that is also according to the guidelines. I mean, any other comments, or Dr. Fox has to make any comment on that?
Are there mics going in the crowd? Yeah. So I think it's...
But in a hospital is for both. I think there is no question, it is in a setup.
Yeah, but
yeah.
But no, I'm giving you a scene where both are generally possible on a routine day. On this particular day, it was lag time for the hospital. So I think we all think we go for thrombolysis. Everybody agrees? We use Elexim or TNKT. We are very proud of, and today is making thrombolysis. This patient received Elexim and this ECG 3 hours later. I'll tell you, one ECG was done around 90 minutes, which was also showing good progress. But any comments? Yes, Bhunesh? You need to get a mic, some mic for Dr. Bhunesh.
See, when you have decided to thrombolyze, have you strategized your that time itself? Because obviously you must have strategized. You must have moved. What is the next step? For example, you would have thought of the possibility of a successful lysis, unsuccessful, or planned. What was in your mind?
I actually didn't hear you. I mean, there is so much echo coming.
Now, when you have asked them to thrombolyze the patient, what was...
You are trying to say how to lyse?
No, not that. What was, have you strategy?
Heart block, no choice, but you need to do an angioplasty to get a good result. But there are some downsides of primary angioplasty one must remember. And the primary angioplasty has a time-dependent loss of efficacy. That means if we had waited for the whole team to come, we would have worsened our 1 hour, 3 hours. So this is going to go if we wait. So waiting is not an option. You have to do something. And in that period, whether you want to thrombolize or do something. These are actually negatives. Watching angioplasty, there is a large thrombus. It can go distally, microcirculate. In this particular case, we had to use a field pack and then in this particular patient. This is another inferior infarct. We had both options available, primary angioplasty or thrombolysis. When you first take picture following an acute infiltrate lesion, the artery is not totally occluded, but you have multivessel disease in this particular patient. This looks surgical anatomy to me. So you just wait and send the patient for, this is a case, and we see this very often. A young individual thrombolized previous evening, we do an angio, and you find only a 40% stenosis here. The patient is classed for medical treatment and has remained for almost 6 years now. So if this was to go for primary angioplasty, the patient would have got a stent in this particular area. We see it so many times that young Indians, 30, 40 coming like this and just a mild lesion. This was somebody who was taken up for angioplasty directly, but we ended up like this, seeing thrombus all along the way to stent. So on, and this is a picture, no stent, no balloon, and the artery looks absolutely perfect. So we see this so often that there is so much of thrombus and very little of cholesterol, and that's why this particular approach could be quite an exciting. And this back, if angioplasty is done.
So there may not be a big surprise in that trying to quality program in a better way. Something which...
First of all, my congratulations to everybody in Kerala for conducting this registry. I think really important step. And I think that we always learn from having secure data. And so that is a really important step. So I've been asked to talk about whether we can improve our... Again, these are my declarations. I'm going to give you a quote. This quote is from epidemiologist predecessors. And what it said was, Glasgow and coronary capital of the world. And what he claimed is that the case fatality was 49% for men. Unfortunately, he only had evidence of definite MI in half of these, and in a small region on the outside of Glasgow, and he extrapolated those findings to the rest of the country. I think his findings were accurate then, and they are not accurate now. Let me give you the WHO data for the age standardized vascular, and you have a huge spectrum from some of the Eastern European countries, very high rates. See that India is in the middle group, and there are some countries in the lower group, and clearly countries like France and Japan are much lower than the rest of us. England, it's 88% within 90 minutes. The use has gone up. The contraindication down, and